and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shammingham. Immune checkpoint inhibitors work by blocking inhibitory signals, or checkpoints, that suppress T-cell responses, thereby allowing tumor-reactive T-cells to mount an effective immune response. Checkpoint inhibitors have been proven effective in multiple cancers, but they carry with them a broad spectrum of unintended immune-related adverse events, friendly known as IRAEs. And these IRAEs include organ-specific and systemic autoimmunity. And as a result, there are concerns about using these agents in patients with pre-existing autoimmune diseases. There's also a concern that pre-existing immunosuppression in rheumatic diseases like rheumatoid arthritis might reduce the effectiveness of immune checkpoint inhibitors. And so when the original clinical trials with these patients were excluded, now that ICIs are more widely used, more rheumatologists are asking whether the current data really supports those concerns. The manuscript we will discuss today is Mortality in U.S. Veterans with Rheumatoid Arthritis Treated with Immune Checkpoint Inhibitors. It was published in Arthritis Care and Research, and a link to the manuscript and disclosures can be found in our show notes from today. I'm thrilled to be joined today by the first author of this manuscript, Dr. Madeline O'Sullivan. Dr. O'Sullivan is a rheumatology fellow at the University of Utah. She grew up in Tulsa, Oklahoma, and completed her undergraduate studies in psychology and human development at Duke University. Following graduation, she worked as a research coordinator for the Duke Pain Prevention and Management Program, and subsequently returned to Oklahoma for medical school. She then moved to Salt Lake City for internal medicine residency, where she was also chief resident, and she's now a rheumatology fellow at the University of Utah. Welcome to the show, Maddie.
Thank you, Vicky. I appreciate the opportunity to join you today to talk about this.
Well, it's great to have you. I wanted to start with the why behind this research. Tell us, how did you get interested in this particular research question, and what stimulated you to do this study?
I think a couple of main reasons. As we know, cancer prevalence is increasing over time, now affecting 1 in 3 adults over the course of a lifetime in the U.S. But along with that comes, thankfully, constantly evolving treatment options. But in the last 10 years or so, 10, 15 years, immune checkpoint inhibitors have really changed the way we see cancer treatment, where, as you mentioned, we're now unleashing the patient's own immune system to fight cancer, in contrast to traditional chemotherapy that actually suppresses the immune system as a side effect. But with that comes a lot of unanswered questions for our patients and rheumatology specifically, our patients with pre-existing autoimmune disease that we need to answer because so many will also be affected by cancer. Thinking about how will our patients with dysregulated immune systems at baseline respond to these treatments. We'll see patients in our clinic receiving immune checkpoint inhibitors with increasing frequency as these have become more commonly used in the treatment of many cancers. So it's really important that we start to address these concerns.
Yeah, definitely. So for this particular study, you used some retrospective data from U.S. veterans enrolled in the Veterans Health Administration database. Tell our listeners more about this data set, and particularly, how did you, as a rheumatology fellow, gain access to this data?
I think a little bit of right place, right time being at the University of Utah. One of my mentors has extensive experience using national data collected through the VA healthcare system. So this includes basically all veterans in the U.S. who utilize healthcare within the VA. And then we selected our patients for this study from that population. And one of my mentors, Dr. Cannon, has worked with this data for many different projects over the years. And through our IRB at our site, we have access to this big national data set.
Amazing. You've just sold the rheumatology fellowship at the University of Utah to all of your colleagues. So tell us more about how you defined the cohorts for this particular study. How did you select the patients you were studying?
So what we were really doing is comparing two groups of patients, those with underlying rheumatoid arthritis and those without. And then all of these patients were exposed to an immune checkpoint inhibitor for treatment of cancer. So what we did first was to find our case and control populations within the big national VA system. We identified RA patients and then matched them to non-RA patients based on their year of birth, gender, the year of their initial VA enrollment. And then from those two big groups, we selected our patients of interest, which were those who received an ICI, or immune checkpoint inhibitor for cancer. The way that we classified our veterans as having RA was using previously validated algorithm. And that meant that the patient had to have 2 or more ICD codes for RA. One of these had to come from a rheumatologist. And then either treatment with disease-modifying anti-rheumatic drug or DMARD, or laboratory evidence, so either a positive RF or a CCP antibody. And then we included patients as an RA case if they met these criteria at any point prior to their first ICI infusion. If they met criteria after that, the date of their first infusion, we excluded them, as our question for this specific study was about those with pre-existing disease rather than de novo inflammatory arthritis as a result of ICIs, which is an interesting but different question altogether.
Yeah, definitely. And did some people receive multiple checkpoint inhibitors? I guess that's not uncommon to concurrently or sequentially receive multiple checkpoint inhibitors. Did you include those patients as well?
Yeah, that's a great question. So we didn't limit this at all, but most of our patients in this study we found received monotherapy. So about 5%, a small minority of our patients ended up receiving multiple ICIs. Like I said, we only required a single infusion for inclusion, as our goal was to evaluate survival based on the initial intent to treat with ICI therapy.
That makes a lot of sense. And then you also collected data on the immune suppressants that the patients who had RA were receiving. Tell us what was included in that analysis. And I guess in particular, how did you assess timing relative to ICI use?
Sure. We used pharmacy data for any exposure to specific DMARDs prior to the first ICI infusion for each patient. We included both CSD-MARDs and biologics with indications to treat RA. And then we looked at these exposures 90 days prior to the first ICI infusion, which we felt was most relevant to answer our question. What we found was that about half of RA patients had DMARD exposures prior to infusion, compared to a very small minority, less than 1% of our non-RA patients, as you'd expect. There's some overlap in the DMARDs that we use to treat RA and cancer, like rituximab and methotrexate specifically. We also looked at steroid use, which gets a little bit more complicated, but I think it's an important piece here to discuss. So to look at patients with steroid exposures, we considered any glucocorticoid exposure at any time and within 90 days prior to their first infusion, ICI infusion. We looked at prednisone exposure specifically, and then we looked at IV and dexamethasone exposure. And the reason we did that was that we felt prednisone is sort of our standard RA flare treatment, whereas IV or dexamethasone would be more commonly used for cancer-related indications. And then we also looked at total cumulative glucocorticoid, dexamethasone, and prednisone during 90 days prior to their first infusion. And then we used this total glucocorticoid exposure as part of our covariate analysis. The bottom line for what we found with exposure to steroids is that they were more commonly used in RA patients, as we would expect. There was more prednisone for RA patients compared to our non-RA group, which is consistent with our standard flare treatment. But the use of IV steroids and dexamethasone was actually similar between the two groups, which we feel is a reflection of steroids being used for those cancer-related symptoms. And in the end, steroid use didn't really seem to make any difference in our mortality outcomes when we included it in our model.
Yeah, great. So that brings us to the meat and potatoes of this study. The primary outcome of your study was mortality. Tell us how you determined and verified death and cause of death in this population.
Sure. So our primary outcome was looking at survival at 1 and 2 years. And then cause-specific mortality was one of our secondary outcomes. So to determine these, we used the Death Ascertainment File, or DAF, which is maintained by the VA and pulls data from multiple sources. And then that was used for our all-cause mortality. And then to look at specific cause of death, we linked to the National Death Index, which is maintained by the CDC.
And I should mention for our listeners from outside of the US, the Veterans Health System has a very unique data set because both you capture all prescriptions and then you do also capture events including mortality, because it is kind of a closed system and once in the VA system, always in the VA system. Is that a correct way to describe it?
Yeah, absolutely. Thank you for clarifying that.
So tell us now how many patients were totally included in this analysis, and then give us a bit of a kind of granularity as to which types of cancers were you seeing treated.
So we ended up with a little over 300 RA patients and then about 2,100 in our non-RA group. Again, all of these were treated with an immune checkpoint inhibitor for some type of cancer. And we didn't limit any sort of cancer subtypes. What we ended up seeing was most frequently lung, which was accounted for about half for both of our groups. And specifically non-small cell lung was most common, and that accounted for about 40% total. And then following lung, we saw primarily genitourinary, gastrointestinal, and melanoma. And then there was a smaller minority of head and neck cancers, all of which have indications with the ICIs.
And what did you find in terms of survival? Was there a difference between the rheumatoid arthritis and non-rheumatoid arthritis groups?
There was no difference in mortality, so survival was fairly low in both groups. 1-year survival, 46% in our RA group and 51% in our non-RA patients, and 2-year survival was around 30% in both groups. Neither difference was statistically significant. And even when we looked at a model adjusted for several factors, including age, gender, race, smoking history, their cancer type, underlying comorbidities, or that glucocorticoid exposure, we found no difference in mortality between the two groups.
And what did you discover when you did secondary analysis of this study's data?
Again, the cause of death was similar in both groups. Most commonly, the cause of death was related to neoplasm. That was in 93% of our RA patients and 91% of our non-RA patients. And then I think another important point is that deaths due to infection were quite rare in both groups, which was less than 1%.
And that's kind of one of the major things that you wanted to look at was both risk and then risk of infection. So it's kind of reassuring for rheumatologists to know that the risk is not greater in the RA population. And certainly for patients living with these diseases, it's reassuring for them, right?
Absolutely. And, we showed that a lot of these patients are on DMARDs. They're receiving steroids prior to their ICI infusion, and there was still no significant difference in terms of mortality related to infection, which is certainly reassuring.
Really important information. So, as all great studies do, your study had some limitations. I wondered if you could walk us through those for our listeners.
Sure. So, you mentioned, I think, one of our main strengths is using the VA data for the reasons that you discussed earlier, but it also sort of raises concerns about generalizability, as our sample included predominantly elderly males, which is consistent with the VA population. But reassuringly, there was a publication in ACR earlier this year by Ann Bass's group, which found very similar results using a Medicare database. So we do feel that our results may be more generalizable in a broader patient population. There's potential for channeling bias with RA patients potentially being selectively sort of steered away from ICI therapy because of these concerns for adverse events and the fact that they were left out of clinical trials because of their underlying immune disease. But again, the fact that patient characteristics, including information about their cancer subtypes, cancer staging, their comorbidities, and healthcare utilization, those things were very similar between groups. And then the similarity in drug selection for our ICIs, treatment patterns overall, we felt that was reassuring that channeling bias wasn't a major issue for our study.
Yeah, no, it's good to hear that. And I think really helpful to understand that background to this specific data set and population. So tell us, where are you planning to take your research next? Do you have more plans with this data set? What's next for you?
Yeah, I think, one thing we did as a follow-up to this study after hoping to provide some reassurance about the use of ICIs in RA patients, we took a look at real-world data and how clinicians have actually used immune checkpoint inhibitors. We looked at ICI uptake in patients with and without pre-existing inflammatory arthritis specifically, and we found that was very similar over time. We presented that as an abstract at ACR last year. We also found that there was no mortality difference between those with and without pre-existing autoimmune disease. I think taking those results and looking at the future, I'd love to be able to address some of the limitations that we just discussed and a couple of the points that you brought up earlier. We talked about a very small minority of patients in this study being treated with combination ICIs, but I think that this is something being used more commonly in the oncology world. So I'd love to be able to look at maybe a bigger subset of those patients. I think there's more questions about steroids and how they're being used in RA patients during the course of their cancer treatment, as there's good data out there showing that these patients will experience flares of their underlying disease. And then I think just continuing to look at ICI-associated survival in patients with other underlying rheumatologic diseases will be important as well. So sort of expanding this outside of RA.
I love that you're thinking about those questions, because those questions are what really matters to patients' care and people managing those patients in practice. So it's really great to hear you're doing this work. I wanted to take you in a slightly different direction now. Kind of amazed you're still a rheumatology fellow in the University of Utah. I'm kind of fascinated to hear, how did you manage to complete this project during your busy clinical rotations? And do you have any tips for our listeners, many of whom are also rheumatology fellows, on juggling research and clinical care during fellowship?
I don't know that I have maybe the answer, but I guess I would say it definitely wasn't easy to get this done. You know, my job as a fellow planning to go into practice, clinical practice at the end of training is to learn clinical rheumatology. So I've had to work really hard to carve out time to make this a priority, and it has taken a long time. But I would say I'm really lucky to be part of a program that values not only research in general, but has really allowed me to sort of tailor my training to get exactly what I want out of it. And I think the other big piece is my mentors, which I'll talk more about in a minute. But I guess all of that to say is that my advice for trainees specifically would be to sort of choose your program wisely and the mentors that come with it when you're looking at different programs, really trying to get a sense of how flexible they might be in helping you get the most out of your training experience.
Yeah, that's really good advice. Tell us then about your mentors and other collaborators who helped you get this work completed. Anyone you want to give a shout out to?
Absolutely. I think this goes without saying, but it was a huge team effort from the start. I definitely would not have been able to do this without our entire group of collaborators. But Tani Broughton is one of my mentors here at the U, and she really helped conceptualize the initial question that we set out to answer, provided her expert guidance along the way. She has sort of specialized training in the rheumatologic effects of immune checkpoint inhibitors. So, of course, she was particularly helpful. And then Grant Cannon is one of the hardest working research mentors out there. I think he's helped launch countless trainees' research careers over the years here in Salt Lake City and beyond. I experienced an unanticipated health problem during the revise and resubmit period for the manuscript, and I really give all the credit to both of them for helping get this across the finish line for me. And then I'd really like to thank our entire group of collaborators, Brian Sauer, Gary Kunkel, Jesse Walsh, Shardul Patel here at the U, and then several others across the country, including Josh Baker, Brian England, Punyasha Royal, and Ted Michaels, who have been an absolute pleasure to work with on this. I've learned so much from working with this group to get this project done.
I guess that also raises an important point that if you're lucky enough as a fellow to work with VA data, you get to meet all these other phenomenal rheumatologists across the country who've invested years of their career working at the VA and caring for veterans and really thinking deeply about this data set and how to use this data set to answer the questions for future veterans. So it's always a great way to connect with other investigators around the country.
Absolutely. I had no idea that I would sort of have that opportunity when I started this project. And that was a really nice unanticipated surprise.
Now, talking of unanticipated surprises, I guess they come as good and bad. What do you wish you'd known when you started this project? And was there anything you wish you'd done differently?
I guess I wish I would have known just how long it would take at different points to get finished. Specifically, it felt like getting a complete draft done was almost the easy part, but then refining and editing and the revise and resubmit, all of that was really tough and it's time consuming. I don't think I would have necessarily done anything differently because it was all such a great learning experience for me. This was sort of the first project that I took from the initial conceptualization of the question all the way through getting it published. I think, of course, you wish you could predict and preemptively address some of the reviewers' concerns before submission, but it was so valuable to learn from their perspectives. And I'm grateful for that because I think that they helped take this from a really solid paper to something that's, even better. It's a great paper.
Well, that's a great kind of lead in to my next question was, how difficult was it as a fellow to get this manuscript written up? Do you have any advice for others trying to get their work published? And I guess shout out to Arthritis Care and Research, where every publication is handled pristinely smoothly.
Definitely. I think my advice as someone at the beginning of their research career is just to stick with it and not give up no matter how long it takes. When you get busy with inpatient consult rotations or other things going on as part of your training, this may sit for longer than you'd like, and you may have to revisit or even update your data, but that's okay because this is really important stuff and it matters for our patients, like we talked about at the beginning. And I would say lean on your collaborators because in my case, like you mentioned, I'm working with this group of people that have vast experience over the course of decades with this data, and they're really eager to help the next generation of researchers, if you will. And I think a lot of other trainees are in a similar position, whether they know it or not. You just really have to sort of seek out and take advantage of that network of more experienced researchers around you. And like you said, I really like to thank Arthritis Care and Research. They were really supportive and flexible, especially in the final stages of submission and revision for this manuscript. They were great to work with on this.
Yeah, so encouragement to all of our other fellows listening in and other researchers listening in. Do publish with the American College of Rheumatology journals. It is a pleasant process, and then all good advice in terms of the nitty-gritty of getting manuscripts written up. So, Maddie, I really want to thank you for sharing your research, sharing your experience with our listeners. Your insights have been invaluable, and I do hope that you continue to keep your hand in with research in the future and that we hear more publications from you in the future.
Thank you so much for having me today.
So I want to close today by also thanking our veterans for their courage and sacrifice in protecting our freedom, and thanking everyone who works in the Veterans Health Administration for their efforts to improve the health of those who have served. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.
This podcast was edited by Resonate Recordings.